This video is recorded for educational purposes only. The procedure has been performed by a qualified trained surgeon in a sterile and controlled environment. It is not meant for diagnosis, treatment, or self-care. Do not try this at home.
Assalamu alaikum. This video is about the left-sided laparoscopic adrenalectomy for a 6.5 centimeter mass in the left adrenal. So the basic steps are mobilization of the colon, and then identification of the gonadal vein, and then following the gonadal vein, this will lead you to the renal vein, and that will lead you to the adrenal vein. Here there is a little bit of change in the anatomy. You can see that there is a bigger vein of the kidney, renal vein, which is draining two veins. One is adrenal vein, which is going horizontally towards the adrenal gland, but the other one is a vertical vein which does not seem to be draining the adrenal vein. Instead it is a lower polar vein. So the decision has to be made about whether to clip the confluence of these two veins, which is draining into the renal vein, or we can dissect this small vein away from the adrenal vein. So what I do is that here I use the hook, monopolar hook, and care must be taken while using the monopolar hook here not to injure the artery to the superior pole. Here you can see the pulsations of that artery. Yes, the pulsations can be seen here. So because it is very near here and is dividing into further branches, and it is also giving one branch to the adrenal gland. So we need to dissect everything away from that artery in order to avoid any injury, and thus the ischemia to the upper pole of the kidney. Okay, the mass of the adrenal gland, it was an incidental finding. There were no related symptoms except for the hypertension, although we were suspecting clinically pheochromocytoma, but all the markers were within the normal ranges, including the cortisol, the dexamethasone suppression test, as well as the urinary VMAs, and also the epinephrines or the metanephrines, plasma metanephrines. Everything was within the normal ranges. The case was also discussed with the endocrinologist, and he also suggested that this is not a pheochromocytoma, so it did not require any prior specific preparation. So here you can see that vein has been separated, and as the adrenal vein is quite big, so I have applied 2 clips on the proximal side. Some would say the distal side of the vein. However, the portion of the vein that is remaining, I have applied 2 clips. Now, dissection of the adrenal gland from the upper pole of the kidney. This is also a very tricky dissection because at times that small artery which is arising from the upper polar artery of the kidney can get injured and can cause a bleed, and at the same time injury to the upper polar artery must also be avoided. So dissecting close to the close to the gland so that that artery is not injured, and also keeping in view that the tumor must not be opened, because we don't know, it is not pheochromocytoma, so it might be some malignant mass. So oncological principles have to be followed. The most difficult part of adrenalectomy is separation from the upper pole of the kidney. So there are three arteries which are coming to the left-sided adrenal gland: the superior, the middle, and the inferior adrenal artery. The superior adrenal artery is a branch of inferior phrenic artery. Here you can see that branch. And the middle adrenal artery is a branch which is coming directly from the aorta, and the inferior one is from the renal artery. So at times while using the ligashore, these arteries may not be identified during the dissection, because ligashore can very effectively control these vessels, and most of the times you don't even know where are these arteries, but an effort must be made to identify these arteries and then deal them accordingly. So here you can see that this is the branch of the superior pole which was supplying the adrenal gland. There is another one, and you can see the branches of the superior polar artery, and we are dissecting away from those branches so as to avoid any damage to the arteries which are supplying the kidney. So this was the branch. So we sealed it with ligashore. Ligashore can seal vessels of up to 7 millimeter of diameter. So you can clip them. This is the parenchyma of the upper pole, and the artery is pulsating. So you can use a small clip, or you can use a bipolar forceps, or you can use a ligashore. Now dissecting the portion of the adrenal gland towards the aorta. Here we will be seeing a small artery which is coming from the aorta towards the adrenal gland. And to be honest, we were unable to identify any superior adrenal artery. Here you can see this is the artery. The lumen seems to be a little big, although ligashore can cover it very easily and can seal it. However, we prefer to apply one small Hem-o-lok clip as well. So we are applying that clip. The artery is controlled, and then we are using the ligashore to further dissect. Personally, I feel that the left-sided adrenal gland is easy to remove as compared to the right-sided adrenal gland, and the reason for that is that you can usually see all the three arteries which are supplying. And secondly, the vein is usually draining into the renal vein. So the pressure in the renal vein is of course is of course not that much of the like that of the IVC, because IVC has got a bigger lumen, contains more blood, so any injury to the adrenal vein on the right side would be considered bleeding of the inferior vena cava. But here, if there is anything, you can control it easily. So personally, I feel that left adrenalectomy is easier. However, some surgeons would suggest vice versa. The vein on the right side is quite short. It is draining directly into the inferior vena cava, and sometimes if the gland is too big, it is pushing on the inferior vena cava, and clipping that vein can be a little cumbersome. So this is the normal part of the adrenal gland. You can see you can move it around here and there, keeping in view the structures, because the tail of the pancreas is nearby, colon is nearby, the splenic vessels are nearby. So while applying the sealing device and cutting it, one must be really careful. So the procedure is performed quite nicely. All the field is very clear, there is no bleed, and we place this specimen into the retrieval bag and then we retrieve it. Thank you very much for watching.